A very common condition children get is coughing and wheezing, and we use this term asthma. What is asthma, Dr. Marcus?
Asthma is probably the most common chronic disease of childhood, and it's one of the most common causes for children to come to the pediatrician's office, come to the emergency room, and come to the hospital. It's a disease whereby the lungs react abnormally when they're exposed to a number of common environmental catalysts. The lungs can react abnormally to viral infections, for example, cigarette smoke exposure, or allergens, things like ragweed, pollen, dust, and molds. But this abnormal reaction leads the lungs to develop blockage, thereby making it more difficult for the child to breathe, leading to the wheezing and the coughing we commonly hear.
If a child coughs and wheezes under a year, is that an asthmatic?
Sometimes it is. Many times it's not. There are many children who will cough or wheeze from viral infections in that first year of life, and these first episodes may happen once and never repeat. What we've learned is that about 25 to 30% of these children who cough and wheeze very early will go on to develop more frequent episodes of wheezing and thereby will be diagnosed as having asthma. But many children will have only one or two episodes in that first 1 or 2 year of life and never have another episode.
Little babies who wheeze very young get a disease called RSV, and they wheeze afterward. Does that mean they're going to be an asthmatic, or that the infection RSV is making them wheeze? What's that story about?
RSV is one of the most common viruses that children are infected with. In fact, within the first 2 years of life, virtually every child has been infected by this virus at least once. Most children who get RSV infection get nothing more than a runny nose, mild cough, which goes away in 5 to 7 days. But about 25 to 30% of these children will go on to develop wheezing and difficulty breathing, and some of these children actually end up in the hospital to care for these episodes. What we've learned is that the children who wheeze from their RSV infection do have a higher risk of developing asthma as they get older, but it is not a 100% risk. And so what we tell parents is that if children are wheezing from their RSV, then we need to monitor them closely over the next several years so that if asthma develops, we can treat it promptly, minimizing future problems.
If a certain group you heard about got it, what group would that be the most risky group? Is that big babies, little babies? What group is that?
Well, certainly there are children who have greater risks of having serious problems when they develop RSV infection. And we've characterized those children into certain groups. The groups that are at the greatest risk are babies who had been born prematurely. Babies born prematurely have lungs which are either not fully developed at birth or have lung development after birth which is slightly different than a full-term baby. This difference in lung development makes these children at significantly greater risk for having wheezing and more serious problems when they get their RSV infection.
These tiny prematures, like maybe 30, 32 weeks, really at high risk. Is there anything we can do so they don't get so sick?
Certainly. There are a number of different strategies that we use. The first, of course, is to try to minimize the risk of getting that infection at the earliest age. So we want minimal exposure to other children who may be carriers of the virus. And we want to make sure that anybody who touches or handles these children wash their hands properly and are otherwise not sick. Once we take these usual precautions to minimize exposure, the next thing we do is to immunize these patients with a new vaccine which prevents the serious form of the RSV infection. This vaccine is called Synagis and is required to be given once a month throughout the high-risk time of year. That is from October through March in the East Coast. In other areas of the country, the risky time of year may be slightly different, but generally we give this vaccination once a month for a 5 to 6 month period during this high-risk period to minimize the seriousness of RSV infection if the premature infants contract it.
When you say premature, how premature does the child have to be considered to get this vaccine?
Any premature child can be considered for this vaccine, and then there are various risk factors which we factor in to decide which child actually gets it or not. But the starting point is always prematurity all by itself. The more premature the child is, the greater their risk, and so the greater likelihood is that they would qualify. Children that are near term, 34 to 36 weeks, would need several other risk factors before they would be required to get the RSV Synagis vaccination.
If a child wheezes and they're very young, many pediatricians today give these kids a nebulizer. Why?
Nebulizer is a device which allows a medication to go from a liquid form into an inhaled or a mist form, thereby allowing the child to breathe the medication in. In certain conditions which result in wheezing, these inhaled medications actually help relieve the spasm in the lungs to improve the breathing, decrease the wheezing, and help the children breathe more easily.
General rule, kids under 6 months don't do as well with nebulization. The kids over 6 months, is that true?
That is correct. What we've learned is that there are a group of children who wheeze who do not respond nearly so well to the nebulizer medication, and 6 months is a very common cutoff for that. So under 6 months, we only give nebulizer medication if we've tested it on the child and we see that they are a responder to that medication.
Years ago, doctors used to give kids who wheezed epinephrine or adrenaline shots. Is there any place for that anymore?
We generally do not use epinephrine or adrenaline shots at this point. What we've learned is that the inhaled medications work just as well as the shot of adrenaline, and it's a lot less difficult for the child to receive.
We know some kids carry inhalers. What group of kids would be more likely that you would use an inhaler over a nebulizer? Is it an older kid, a certain type of kid? What would that be?
An inhaler is a device that administers medications into the lungs in the same way that the nebulizer administers medications in a way that allows it to go into the lungs more easily. The choice of using a nebulizer versus an inhaler depends upon the child, their age, and their ability to do the medication administration properly. The metered dose inhalers and dry powder inhalers that we presently have require a certain amount of skill and practice for the child to perfect in order for the medication to reach the lungs in an effective manner. We generally use spacers attached to some of these devices to help this technique, again to allow the medication to be inhaled properly. What we do is we look at the child's age, we see if he's able to take these inhalers in a proper fashion, and if in fact they can, then we present it as an option. The advantage of the inhaler is twofold. One, it's small, able to be placed in a pocketbook or a pocket or a briefcase, and therefore can go with the child wherever they are, allowing him to have his medication in a very simple fashion. The other is that the inhaler takes far less time than the nebulizer. In a matter of seconds, they could have their medication in their lungs, where with the nebulizer it may take anywhere from 5 to 10 minutes, depending upon the specific device.
If a kid used an inhaler, what group or age group that you would probably consider that over a nebulizer?
There are some children as young as 7 and 8 years old who can use an inhaler properly, and I've seen 12 and 13-year-olds who are still not using it right and are still better off using the nebulizer. The nebulizer gives the medicine in an easier and more reliable fashion. It only has the inconvenience of taking longer to administer and being required to have the machine with you if you need it on the road.
If you had an inhaler and they shake it and they hear some noise and it seems to some weight, can you be sure there's medicine still inside that inhaler?
It's tricky. There are some inhalers where we can judge if a medication is there just by the way it feels. There are others where it does not. You need to take a look at the specific instructions of the device. Each device has its own technique for telling whether you have any medication left or not.